Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
It's Dr. Uvo Norebia with Healing Hands Health Society and a current resident at the University of Michigan graduate prosthodontic program. And we have a very special guest, a former resident many years ago before I got into dental school, Dr. Sameh El-Ebrashi. He obtained his dental degree from the University of Newcastle in the United Kingdom in 1993. And after working in private practice, he completed his prosthodontic residency at the University of Michigan and received a Master of Science in 1998. Dr. Ebrashi is a board-certified diplomate of the American Board of Prosthodontics and the American Board of Oral Implantology. He served as an assistant professor and director of the preclinical removable prosthodontic program at Oregon Health and Science University from 2002 to 2006. Dr. Ebrashi has lectured nationally and internationally and is active in local continuing education programs, and is a guest lecturer at the Oregon Health and Science University back in Portland, Oregon, in their postgraduate periodontology residency. He actively continues to collaborate in research involving implants and immediate loading protocols. He's a member of several professional organizations. He's also a fellow of the American College of Prosthodontics and a member of the Academy of Osseointegration, as well as the International Team of Implantology, ITI. He currently works in private practice, and it's a pleasure to have you, Dr. Ebrashi, speaking to the whole of Africa on this webinar today. Welcome.
Thank you, Uvo. Can you see my screen?
Yes, I'm going to stop sharing so you can go ahead.
Okay, thank you everyone for joining. A little bit about my background. Originally, I'm from Egypt. I'm a third-generation dentist. My grandfather was a dentist in the Egyptian army. My father was a dentist who graduated from the University of Cairo and then worked at the University of Alexandria. He got a scholarship to come to the States in 1962, and he came to Boston and did his master's degree at Tufts, and then he ended up going to Michigan to do his PhD. He returned back to Egypt in 1969 and was a professor at Cairo University until he passed. He was also in private practice, and so I've been exposed to dentistry since the age of 14. I first started working in my dad's office when I was 14, and I used to assist and mix alginates and clean and everything. And so I understand that dentistry in the developing world can be a little bit different to perhaps so-called first world nations. But I think the way we treat our patients and how we interact with humanity is the same across the board. So the reason I'm speaking to you about COVID is because I was faced with a lot of questions. We shut down our clinic on March 17th for 6 weeks when the pandemic hit the US, and I was being asked a lot of questions by my staff, by my family, really by a lot of people, to which I had zero answers. So I want to share my knowledge with you, my experience, and we're going to have about 40 or 50 slides, then we're going to stop for some questions, and then we'll continue. So we should know to practice safely again. Well, there's several things we need to know. We need to know about the actual virus itself, its anatomy and virology. What are the clinical course and what are the risk factors that we need to be cognizant of? What are the modes of community disease transmission? How is it transmitted in the dental office? is aerosol as much of a frightening thing as everybody says it is? What is the R0 and the case fatality ratio? What's the difference between CFR and infection fatality ratio? What is the hazard protection hierarchy? What does that mean? What types of respirators are we using? Do you have access to an N95? Do you have access to a level 1, 2, 3 surgical mask? Do you have access to a surgical shield? Can you reuse or decontaminate these things? And if so, how many times? And what happens if you damage something like that? And what impact does the built environment where we practice have on success and failure? What about the use of MERV and HEPA filters and ultraviolet germicidal irradiation? And then a couple of acronyms, the 5 Fs, the 5 S's, and the 7 Cs. So in the beginning, we know where this disease emerged from. We think it emerged from a wet market in a Hubei province in China, a place called Wuhan. And
Sir,
the disease,
can you hold on?
so SARS anatomy and virology, the clinical course of the disease, the risk factors, modes of community disease transmission. Obviously, we're all concerned about aerosol. What is the R0, the reproduction number, and the case fatality ratio compared to infection fatality ratio? What is the hierarchy of hazard protection? What does that mean to me as a practicing dentist? What can I do? N95 respirators versus level 1, 2, 3 surgical masks, KN95s, surgical shields, PPE, and we're going to really spend some time talking about numbers 5 and 6, the hierarchy of hazard protection. Think of it as a shield with concentric rings, and the bullseye is the PPE. That is your last level of protection. How can you use the other layers of that shield to protect yourself? There are more effective things that you can do prior to getting to the last little piece, which is the personal protection. What about N95 reuse and decontamination? Is that possible? And is it safe? What is the impact of what we call the built environment where we practice in our clinics and the use of HEPA filters and ultraviolet radiation? Is that even a thing? And the 5 Fs, the 5 S's, and the 7 Cs. And so we know where the disease emerged from. It's the name of the disease is COVID-19. The pathogen is severe acute respiratory syndrome coronavirus 2. It is from the beta coronavirus family. It's from the same family as severe acute respiratory syndrome coronavirus 1 and Middle Eastern respiratory syndrome, which were both zoonotic diseases, meaning that there is an intermediate animal host. We think initially these viruses come from bats, then they're transmitted to an intermediate host. With MERS, it was camels. With SARS, may have been a different animal. And then with COVID, we think it really comes down to these wet markets and placing wild animals in cages next to domestic animals, and then perhaps somebody killing one of these animals and having a splatter or a blood drop enter their bloodstream, essentially. SARS-CoV-2 is highly homologous to SARS-CoV-1. There's a lot of similarities between these two diseases, but there are some fairly significant differences. And these two diseases enter the human body through the angiotensin-converting enzyme 2 receptor. The difference is SARS-CoV-2 has 10 times the affinity to the ACE2 receptors compared to SARS-CoV-1. SARS-CoV-1 was also a disease that caused fairly significant illness. When you got sick with SARS in 2003, you felt pretty poor, and so you tended to self-isolate. The problem with SARS-CoV-2 is, or COVID-19, which I will use synonymously, is that you can feel reasonably well and be an asymptomatic carrier. And it is transmitted rapidly to what we call a naive human population or susceptible patients. And as we all know, this pandemic is throughout the world. I think the US, as of this morning, has more than 2 million cases and rising sharply. Different parts of the world have handled it with different degrees of success. And I read an interesting paper this morning, which I didn't include, that talked about latitude and relative humidity and so on. So depending on where you are in the world, the population density and the amount of exposure to folks traveling from countries or cities with high rates, there may be imported cases. And when we look at the actual virus itself, we know it is a lipid envelope virus. It's a fairly simple thing. It's an RNA virus. It's around 120 nanometers, or 0.12 microns. I need you to remember that number, 0.12 microns, because we're going to be talking about the efficacy of N95 masks. It does have a phospholipid membrane, and that's the way you destroy it. And it has this spike glycoprotein. So that's how it attaches, and that's how you destroy it. Hence, one is in red and the other is in yellow. It's a fairly simple thing to break down with soap and water, effectively. And viral replication, I think you all know how viruses replicate. They attach to the host. Here are the ACE2 receptors, which are found in the upper respiratory tract, lower respiratory tract, GI tract. And so depending on the size of the molecule, it will attach to ACE2 receptors, typically in the upper respiratory tract or the nose, as you breathe it in. Well, what happens if you get a droplet in your mouth? Is it able to attach to ACE2 receptors in the salivary glands? It can. And what happens if you ingest a sufficiently high amount? Will that then be able to attach to ACE2 receptors in your GI tract? That's possible too. And if you actually inhale something that's what we call a droplet in the respirable range, less than 5 microns, that is able to go to all the way down to the bottom of your respiratory tree, to the alveolar duct or the sac. Anyway, it attaches, it then releases its viral RNA, it tricks the body into producing clones through a process of transcription and translocation. Then you produce additional viral cells, which you release into the bloodstream. You then become sick or not, and then you're able to transmit those. So it has an RNA nucleocapsid. Here is the spike protein with which it attaches, and then the phospholipid membrane is how you destroy it. And by destroying the phospholipid membrane, you now have access to the nuclear material or the RNA. If you can destroy the membrane, then essentially the whole thing is inactivated, and it's not held together by strong covalent bonds. And so when we look at this disease and how it showed up in China, they think that it started off in this wet market in Hubei. Then they started to have transmission across other provinces in China. On the 1st of January 2020, they shut down their wet market. And on the 23rd of January, they had a lockdown. But by that point, the genie's out of the bottle. 27 out of the 41 original cases were traced back to Wuhan, which is in Hubei. But once you start to get community spread, especially since there's so much travel in China around Chinese New Year, asymptomatic patients are traveling to other parts of the country and infecting other patients. And by the time the alarm bells were raised, we knew it was too late. And it's interesting, when you look at a country like South Korea and the US, they were both at the same level around February 25th. We know what's happened in the US, and if you look at the statistics in South Korea, they were much more aggressive about testing, asymptomatic testing, and contact tracing. So if the genie's out of the bottle and you have widespread community spread, it's a fairly difficult thing to contain without quarantine and what we call NPIs, non-pharmaceutical interventions. And we all know what's happened across the world in the last 2 or 3 months. As we've shut down, we've flattened the curve, but as we're opening back up, the rates are rising at a fairly alarming incidence. To give you an idea, in Texas yesterday, they had 6,000 cases in a day. And the CDC released a statistic yesterday. They actually think that the rate in this country is 10x of what it's being reported. So we have 2 million cases. They think it's actually more likely to be 20 million, which is still less than 10% of the population, but it's a fairly significant amount. Let's look at clinical course and risk factors with severe disease in China. So these are patients that were very sick. 191 patients that were admitted to a hospital, and let me pause there for a second. If you have 100 patients, 80 have mild symptoms, febrile illness, flu-like illness, you may feel run down, you may have myalgia. 15 are going to have fairly severe illness, and 5 have critical illness. 5% of those patients are going to be admitted to the ICU, and approximately 50% of that 5%, so 2.5 patients, are likely to die. So in this instance, it's 191 patients that were admitted to hospital. They were all very ill, 54 died. The symptoms they had with mild infections, not with these patients, are the following: fever, cough, sputum, fatigue, myalgia, diarrhea, nausea, and vomiting. And to give you an example of what we're doing, we're measuring temperatures twice a day, in the morning and in the evening, of all of our patients and all of our staff for the last 6 weeks. And it's pretty interesting to see your temperature changing. And unfortunately, I think I was exposed 8 days ago. I'm not certain. I've had a test, it's come back negative. I'm now doing antibody testing to see if I have any antibodies. I did test a month ago with antibodies, and that came back negative. If I test positive with my antibodies, that means I have been exposed, and I'm one of those patients that had mild symptoms. Loss of sense of taste, or change of sense of taste, or change of sense of smell are rare symptoms, but they are much more predictive of COVID-19. So it is a little bit of an odd symptom, but it is much more indicative compared to a symptom such as a fever or cough, which a patient can have if they have influenza or the flu. So those are things you should be asking your patients. The disease course, time from illness onset until hospital admission is roughly 11 days, with an average of 8 to 14. Severe disease manifests as an oxygen saturation below 93% and tachypnea more than 30 breaths per minute. 48% of the patients that were hospitalized had comorbidities: hypertension, diabetes, and coronary heart disease. We think patients who have a higher rate of systemic inflammation are more prone to this disease. And there is something called a cytokine storm or hyperactive immune response. The mean duration of viral shedding is 20 days, with a range of 8 to 37 days. One of the patients who died was shedding virus up to day 37. 54 out of 191 patients died, and the odds of an in-hospital death increase with age. The older you are, the higher the ratio of you being hospitalized. Some of that may be related to the fact that you may have some of these other comorbidities, such as hypertension, diabetes, heart disease, stroke, liver disease, kidney disease, and there is no correlation with cancer, they found. Clinical manifestations, typically patients have a pneumonia, viral pneumonia, which then may end up having a bacterial or fungal pneumonia added to that. Patient is out of breath. They enter in something called acute respiratory distress syndrome. And this word, hypercytokemia, means a hyperactive immune response. And we don't know a lot about what a cytokine storm is, except for a very aggressive response by the patient's immune system, which can lead to death. And you'll typically see something called a ground glass opacity with a patient who has a pneumonia. They are hypoxic and they may need mechanical ventilation. That could be something like a CPAP, or they may need to be intubated. And they may end up getting acute cardiac and renal injuries. So when we look at the course of the disease and the types of treatment that were given, 181 patients, 95% were given antibiotics, potentially due to the secondary bacterial pneumonia. We look at the difference with the patients who received steroids and immunoglobulin in terms of recovery. It's fairly significant. And most of you have read that in Oxford, they found that using dexamethasone, which is a systemic corticosteroid, can help reduce inflammation and help with these severely ill patients. So there's an evidence of higher discharge rate and lower mortality when you give a patient IV IgG. What does that mean? That means you're giving a patient intravenous immunoglobulins that are effectively anti-SARS-CoV-2 antibodies. So what does that mean? I get sick, I mount an immune response, I recover, my body now has an elevated titer of IgG and IgM, typically IgG. We then use something called convalescent plasma, where you're able to take some of my plasma, infuse that to a sick patient, and now you're giving them antibodies, allowing them to recover. So when we look at the course of this, in the beginning, patients have fever up to about day 12. They're coughing more or less from beginning to end. This is a patient who survived, by the way. They have dyspnea or shortness of breath from day 7 up to day 19. They're admitted to the ICU. They have steroids around day 12. They are RNA positive, and we're going to talk about something called the RT-PCR. So they are testing for SARS-CoV-2 RNA all the way through the infection. They develop sepsis around day 9, and then acute respiratory distress around day 10. Discharge around day 22. Now let's have a look at a patient who didn't survive. Similar disease course: fever up to day 13, cough up to day 16, shortness of breath from day 7 till the patient perished, ICU admission roughly the same time, invasive ventilation. By the time a patient's on a ventilator, they've got a pretty reasonably high chance of not making it. I think the statistics in New York, the patients who were mechanically ventilated as they were really struggling, 88% of those patients died. So if you get to that stage, there's a pretty good chance you're not going to make it out. Again, steroids were administered, and you can see they were RNA positive. Similar disease course: sepsis, ARDS, acute cardiac injury, acute kidney injury, secondary infection and death. And they were actually able to look at markers like interleukin-6 and then troponin, which is a cardiac enzyme, and they found that these enzymes were rising, and basically the cytokine storm was causing a lot of the damage. So how are these diseases, or this disease, transmitted? Well, we know with any infectious disease, you got to have a susceptible host, an infectious agent, a reservoir, a portal of exit, a mode of transport, and a portal of entry. And in Egypt, we have a couple of diseases which we're struggling with. One of them is hepatitis, and some of that is transmitted through the use of something that we call a shisha, or that people are smoking, and it's transmitted. And then the other disease that hasn't been eradicated, but they're working on it, is schistosomiasis, which is a disease that's transmitted in the Nile through snails, and you got to break this chain of infection. And so the best thing to do is to put a barrier at the portal of entry, or eliminate the reservoirs, or try to be cognizant of where the disease is most susceptible, and that's where you attack it. Obviously, prevention is better than cure. And we know in dentistry, this is an interesting picture that was sent to me by a friend in Arizona. This is what a prosthodontist bench looked like after they did their own surgery and their own conversion for an all-on-4. And here is the case with an implant being placed, 2 implants that have been removed. And obviously, there's a lot of potential for splatter and aerosolization. And so there's something called nosocomial infection. Nosocomial infection is infection in a hospital setting or in a dental clinic. And so how do we prevent infection from the patients to us and vice versa? How do we break that chain of infection? And we know that these diseases may be transmitted through droplet contamination, essentially me speaking loudly and a drop coming from my mouth and landing on the patient. That could be the patient giving it to me, or maybe me to the patient. We know that these droplets can be transmitted and can land on a surface. Perhaps when we take off our gloves, we put a hand on that surface, and then we touch our eye or our nose. And there was a piece of research from Australia where they looked at medical students, they videoed them for an hour, and they touched their face 23 times in the course of an hour. 40% of those contacts were to mucous membranes. That means the eye, the nose, or the mouth. And there are case reports of conjunctivitis and viral transmission. So we have the potential for aerosol transmission. Obviously, we're using high-speed handpieces and ultrasonics and piezoelectric handpieces. And then there's the potential for splatter, which are larger liquid droplets, which impact a surface, and those, when they fall, they break and they splash. And so this is a little bit of a complicated slide, and I want you to think along three axes, the X, Y, and Z. Transmission of a disease doesn't always equal infection. It depends on the following. Host resistance. So what can you do to maximize your resistance? The virulence of the microorganism and the exposure frequency. The closer you are to the epicenter, the more likely you are to get infected. So were all those healthcare workers that were infected in Italy infected because they had inadequate personal protective equipment, or was it the exposure frequency, or they didn't know enough to understand that when a patient is breathing, that they can exhale droplets? So something so simple as a patient wearing a mask, obviously they can't wear a mask while you're working on them, but while they're in the waiting room, if you still have patients waiting in your waiting room, and you wearing a mask can really cut down on the amount of egress of bacteria and virus in your clinics. So let's define things, because this was one of the things that I found confusing. What is an aerosol? An aerosol is basically particles suspended in a gas. When you sneeze, that's an aerosol. It's a relative, not an absolute term. What does that mean? That there isn't a cutoff point for a particle size for it to be aerosolized. Studies classified droplets using particle size with the following broad concepts. Droplets less than 5 microns to 10 microns. Those are more or less aerosol, and they are transmitted over short and long distances. So when you think about that, that's when you sneeze and those micro droplets can travel for a long distance. To make things more confusing, there's something called droplet nuclei, and we're going to talk about that. Particles less than 10 microns penetrate below the glottis, and particles less than 5 microns can go all the way down into the bronchi, where they're attaching to the ACE2 receptors in something called type 2 pneumocytes, which are the cells that fabricate surfactant for your lungs. That's where the damage is most severe, because what happens is those cells don't produce enough surfactant. You then start to have pulmonary edema, you struggle to breathe, your body mounts an immune response, and now you're in a vicious cycle, what I call a feedback loop. Droplets that are more than 20 microns, they have a more ballistic trajectory. Those can be blocked by just routine surgical masks. They're too big to be inhaled. And droplets in the 10 to 20 micron range, what I call intermediate droplets. They settle quicker than the small drops, and they may have a smaller titer compared to a large droplet, which is 100 microns. The bigger the droplet, perhaps the more viral content there is in there. Aerosols also include these things called droplet nuclei, which are tiny, tiny little drops that were fabricated or made by evaporation of respiratory droplets. So think of it this way. You have a continuum. You have big drops when you sneeze that fall to the ground quickly, and then you have intermediate drops that can travel, and then you have these respiratory droplets that can be evaporated and go a long distance. When I say a long distance, I'm talking 24 feet, 6, 7 meters, 8 meters. And so there's something called the gravitational sedimentation rate. When you sneeze, the big drops fall roughly within 6 feet, hence the 6-foot social distancing. A sneeze velocity is roughly 50 meters per second. A cough velocity is roughly 10 meters per second. Aerosol droplets are less than 10 microns, and the large spray droplets, they may travel a long way in something called a gas cloud. So droplets can be transmitted via direct or indirect contact, can be on a surface, you touch it, you then put it in your eye. That's what I call indirect contact. Direct contact is when a patient sneezes in your face. That doesn't happen very often. So what's the required viral titer and frequency exposure for us to get sick? And that's a very tough question to answer. And so measles is a highly transmissible disease. The R naught of measles, and I'm going to define that for you shortly, is 12 to 18. Ebola is not so transmissible, yet the case fatality ratio of Ebola is much higher. So big drops fall rapidly, medium drops travel, and tiny, tiny droplet nuclei travel further. So aerosol droplets in the respirable range, which is less than 5 microns, they're airborne for significant time and distance. And all of this is affected by temperature and humidity. So let's talk about temperature. The higher the temperature, so if you live in Africa and you're in a climate that's around 40 degrees Celsius, outside, the virus doesn't survive for very long. If you have high humidity, it doesn't survive for very long. Our clinics are not 40 degrees Celsius. You know that. You have air conditioning in your clinic, some of you. Sunlight can destroy the virus. The problem is, when you look at UV light, there's UVA and UVB, which is what's reaching the Earth, and they're very low of something called UVC. UVC light is germicidal radiation that needs to be in the 254 nanometer range. That's produced typically by machines. And so this is a little bit complicated, but I want you to look at the content. Inhaled droplet nuclei, less than 5 microns, can reach the alveolar space. This is the host. Transfer of a dried airborne contaminant on an environment, it's basically a droplet from a patient landing on a surface that wasn't cleaned. You put your hand on it, you touch your face, or you rub your nose, then you can get sick. Re-aerosolization of a dried airborne contaminant, that can be a problem. And then retention of an inhaled particle in the tonsil or going all the way to the GI tract. But air is a great equalizer for us. A patient may choose what they eat or drink, but generally we don't have a lot of choice in the air that we breathe. I grew up in Cairo, and I was always surprised when I went home every summer and I would say to my dad, I was like, man, the pollution and the noise. And he worked in downtown Cairo, not far from Tahrir Square, about a mile away from there. And I was always just surprised by the noise and the pollution because I was going to boarding school in England, but that's a different story. This is a diagram of a restaurant in China. One patient or one guest had the virus, and the people that were within the air conditioning stream of him, these are all the other people that got sick on the same side of the room. The other side of the room, that didn't happen. In South Korea, they had a similar story in a call center. One side of the room, the call center, one patient was sick, and the air conditioning flow got everybody on that side of the room sick. On the other side, nobody. So I do think there is potential for airborne transmission. What are the non-pharmaceutical interventions that are being used? Well, we know what they are. It's social distancing, it's keeping your patients in the car, it's limiting the number of patients you're seeing, it's really trying to create more break between patients and minimal overlap, which of course is going to affect our clinics financially. And something so simple as flushing the toilet can create aerosol. This was a paper that was just published. And so there's a lot of turbulence when you flush. There's an upward velocity of 5 meters per second, and 50% of the particles reach 1 meter from the ground. So shut the lid, clean the seat before, and absolutely wash your hands after. 1/3 of women, when they left a public bathroom, hadn't washed their hands, and 2/3 of men hadn't. So washing hands is very, very important. So let's talk about the incidence of COVID. And it's been difficult to measure in this country. And I'm sure it's difficult to measure in Africa too, because we're not walking around and we're testing everybody. But there was a couple of situations. One was the Diamond Princess ship, where they were stuck basically off the coast, and they were able to look at the incidence there. And then this paper was published in the New England Journal of Medicine, which I believe for the Journal of American Medical Association, New England Journal of Medicine, all their articles on COVID are available for free. And that's where I'm getting my information from. So in this particular paper, they looked at women who showed up at the New York Presbyterian Hospital to deliver babies at an obstetrics clinic. 215 patients showed up. 4 out of the 215 were symptomatic, so they tested them, and those patients were positive for COVID. Then they realized that some of the staff were getting sick because the asymptomatic patients were transmitting COVID to the nurses. They tested the remaining 211 patients who were asymptomatic. Out of the 211 asymptomatic patients, 29 were positive. That's a 14% prevalence. That means in this country, that's close to 50 million people. And worryingly, when you look at the total number of positive patients, which were 33, the 29 and the 4, 29 out of 33 patients who were positive for COVID were asymptomatic. I'm going to find out in the next few days whether I was one of those patients that was asymptomatic. And I had it without knowing. So let's talk about transmission. If you're infected and you have close contact, speaking, especially speaking loudly, that can go ahead and put particles in the air that somebody close to you can inhale. Sneezing and coughing, or rubbing your nose or putting your finger in your mouth, touching a common surface like a door handle, and then somebody else touching that surface. So you're getting deposition, transfer, and now you're getting susceptible host. So very, very important that we keep our hands clean. And I probably wash my hands 20 to 30 times a day, but with the number of patients that I see. So exhalation, coughing, sneezing, and talking. We do think that there's potential for fecal-oral transmission. Nobody really knows. Contact, we know it's possible, direct or indirect, although people are saying that perhaps it's not very likely. Droplet infection, respiratory tract of infected patients to their mucous membranes, and airborne transmission. And you know who these are. This is Tom Hanks and Boris Johnson. 40 to 50% of patients are pre or asymptomatic, and they are the silent transmitters. 90% of patients do develop some symptoms within 2 weeks. The problem is those symptoms can be vague, and they can confuse you if you are the patient who's sick, such as a fever. There is something called a super spreader, where 20% of the patients are able to spread more or less 80% of the germs or the bacteria. And there was a patient at the turn of last century, they called her Typhoid Mary. She was a woman who had typhus, and she was asymptomatic, and she spread it to 50-something odd patients. So there is a super spreader concept. There are also super spreading events. Super spreading events is where you put a lot of people in a room, and you close the door, and you have them either sing or shout or eat. And there was a choir in Seattle where maybe 60 people were in a room for 2.5 hours. One patient was sick, 45 other people got it, and 3 died. In Wuhan, China, right before the outbreak, they had a potluck dinner, and they tried to break the Guinness World Book of Records. 40,000 people in a hall sharing something called a potluck, where you basically, a hot pot, where you're sharing the same soup. And sadly, as you've seen recently, there are rallies in states like Arizona and Tulsa in this country, where the president is having 2,000 or 3,000 people in a room where nobody's wearing masks. That's a super spreading event, and people showing up at such things as Black Lives Matter rallies and so on. Those are all potential sources of infection. Congregated settings are things like nursing homes, meatpacking facilities, cruise ships, high density where one worker can get other people sick, car factories, and so on. So what is the RT-PCR test? It is the gold standard of airborne virus testing. And it's a nasopharyngeal or oropharyngeal swab. And RT-PCR stands for reverse transcription polymerase chain reaction. Basically, you're taking a swab, and then you are reverse engineering the transcription process, and you're detecting viral RNA. It detects viral RNA, not infectious virus. It measures the amount of virus. It needs to be a sensitive test. And what is sensitivity? A sensitive test is something that gives you a measure of the true positive rate. In other words, if 100 patients are sick, and you do 100 tests, and 100 come back as positive, that's a highly sensitive test. The problem is this is technique sensitive. So you don't always get a true sample, which means you can get a false negative. A false negative means the patient was sick, but didn't test as sick. So a specific test or specificity is more important, because that gives you a measure of true negative rate. So let's imagine we have 100 patients who are not sick. We measure all 100, and it comes back as 100% have zero illness. That's a highly specific test. The problem is the viral load builds up over time and declines. So there is no test that's 100% sensitive and 100% specific. False negative is a much worse thing than a false positive. And depending on where you're getting your sample, bronchial samples have 93% PCR positivity, sputum is 72%, nasopharyngeal is 63%, and pharyngeal is 32%. So the site of sample collection. And to discharge a patient, or to say a patient is no longer sick, absence of fever, clinical remission of respiratory symptoms if they had them, check the CT if the patient had ground glass opacities, and 2 negative RT-PCR tests 24 hours apart. This is a little bit of an important slide. So the lower the number on the CT, the higher the viral load. So this is inverse. And so when we look here, CT is the number of replication cycles required to produce a signal. So initially, patients start with a high viral load, and with time, you get a logarithmic reduction. At day 21, more or less undetectable. And in this study, they had 94 patients, 414 oropharyngeal swabs, high viral loads soon after symptoms. They decreased the detection limit at day 21, and no difference in load by gender or age. So the questions that you have, or I have, at what point is the patient infectious? At what point is the virus no longer detectable? And does the presence of virus in the RNA sample means the patient has an infectious dose or an inoculum? So now let's have a look at fecal samples compared to throat swabs. Same patient, so on the left side is the throat swab, and on the right side is the same patient tested for stool. What they found was stools were positive for RNA 11.2 days after a negative throat swab. But does that mean that RNA in the feces equals an infectious patient? Not sure. If we don't think this is transmissible fecal oral, then perhaps not. SARS-CoV-1 was, because there was an index case in China where there was a leaky sewer and so on, and patients were getting sick. And so when we look at the virology, pharyngeal viral shedding is high in the first week of symptoms, and it peaks on day 4. The infectious virus from the throat and the lung-derived samples, not from stool samples, was high, not from stool samples, high viral RNA. Blood and urine never yielded virus. Okay? In other words, infectious virus tends to be from the throat and the lung, not from the stool, because they did culturing on the stools and they couldn't culture. Shedding of viral RNA from sputum outlasted symptoms, and patients seroconverted 6 to 12 days. That meant that they actually started to mount an antibody response. And so I want you to ignore the bottom half. A positive culture stopped at around day 8. meaning infectivity after day 8 went down significantly. You had a higher rate of negative cultures after day 8. So perhaps patients are infective up to day 8, but the RT-PCR may still pick up enough viral load to register as a positive. And we know this disease has come from the outside in. They think there are several strains. The index case in this country was in Seattle. And then lots of patients were coming from Europe, and that's why you had the high case load in New York. So disease transmission may depend on population behavior, density, social organization, socioeconomic conditions, and some degree of seasonality. I suspect that the rates of COVID are going to be higher in a city like Lagos or Cairo than perhaps a small city or a village on the Nile Delta in Egypt. I think it is going to be related to population density and how much people are connecting. Incubation, we think, is 3 to 7 days. Obviously, there's a silent transmission potential. R0 is the reproduction number, the number of secondary cases produced by a primary case. How many people do I get sick if I'm sick? Is it 2? Is it 2.2? Is it 2.5? Is it 4? Is it 5? Case fatality ratio is number of deaths divided by number of cases. To give you an idea, SARS-CoV-1 had a 10% fatality. MERS had a 34% fatality, and influenza 0.02. Patients at risk of infection, all age groups. Healthcare workers may be more exposed due to poorer precautions or increased exposure to sick patients, or both. When we look at the reproduction number on the y-axis, or the vertical scale, compared to case fatality ratio, we can see Ebola has an extremely high case fatality, more than 15%. But its reproduction number is low. Measles, on the other hand, is highly infectious. We think COVID is somewhere in the 2.2 to 2.4 range. Nobody really knows. R0 is not a constant, though. It's an estimate using mathematical models, and your mitigation strategy is to try and get R0 below 1. If I'm sick and I get less than one person sick, the disease goes away. Now I want you to use your mathematical mind. If 50% of the population uses a mask that's 50% effective, 50% adherence of the population, 50% efficacy, R0 goes to about 1.35. What does that mean? It goes from 2.4 to 1.35. That's a whole order of magnitude. Mathematically, that means if you have 100 cases at the beginning of the month, with an R0 of 2.4, it equals 31,280 cases. It's a superlinear, linear, or logarithmic scale. You've seen the exponential curve, compared to 584 cases. So something so simple as wearing even a homemade mask makes a huge, huge difference. If we can get 60% of the population to use masks that are 60% effective, R0 becomes 1. That's it. If you can have people wearing masks, the rate of transmission goes down significantly. And when we look at immunization coverage, the higher the immunization coverage, the more herd immunity we have. So have a look at this. Mask utilization is more effective with high compliance rates. So when you have a higher vaccination percentage, you get more community protection. So measles has an R0 of roughly 12 to 18, highly transmissible disease. That means one patient gets another 12 to 18 folks sick. That means we need to have about 90% of the population vaccinated to achieve herd immunity, so-called herd immunity. For COVID, they think that since the R0 is roughly in the 2 to 3 range, you got to have around 60% exposure to have herd immunity. 60% of the population has to have been exposed for us to have so-called herd immunity. Now, as you know, there are other countries such as Sweden and Iceland that have done taken a different approach, and they have adopted a herd immunity approach. The problem is the most vulnerable people are the ones that are going to die. And when we have a look at the index case in Seattle, was in a nursing facility. They had 129 folks get sick, 81 residents, 34 healthcare workers, 14 visitors, and the average age of the residents was 81. They ranged from 54 to 100. The healthcare workers were younger. Average age was 42.5. Range was 22 to 79, which is surprising. And the visitors were from 52 to 88. And what they found was 22 patients out of the 23 who died total were the older patients. Those are the most sick patients, and their rate of comorbidity was high. 56% had hypertension, 46% had cardiac disease, 35% had renal disease, 30% had diabetes, 27% were obese, and 26% had pulmonary disease. So CFR depends on age, comorbidity, outbreak setting, and the health system capacities. And when we look at death rates by age cohort, there's a trend. South Korea, China, and Italy. Older patients have a higher mortality rate. And in Italy, it was high, and patients over the age of 80 was 20%. Now, they have a high percentage of patients over the age of 70. You can see the range is 6.8 to 7.2. In China, it's 2.3 to 4. I'm not sure about the veracity or the truth of that. And in South Korea, it's around 1%. So why is that? Why do we think that the fatality rate is so low in the young compared to the old? And initially, I have 2 young kids. They said, well, we're safe. We can't get it. I said, I'm not so sure about that. And so this is a pictogram that shows log viral loads estimated from RT-PCR based upon age. So 1 to 10 years old, 11 to 20, they have the disease. Just the viral numbers are lower. And then once you get to the age of 21 to 30, they've got 536, that's the category count, 630, 575, 662, 431. So basically, once you become an adult, the numbers jump significantly. And why is that? Why do we think that is? It's all to do with ACE2 receptor gene expression in younger patients compared to older patients. So here they looked at patient by age group, below the age of 10, 10 to 17, 18 to 24, and more than 25 years old. We can see there is statistically significant difference between this group and that, highly statistically significant difference between 17 and 24, and a very big difference between adults and children. And so there is an age-dependent expression of ACE2 receptors in the nasal epithelium, which is the first point of contact. And we know there's a lower ACE2 expression in children versus adults. Perhaps that's the reason why children contract this disease less than adults. And so how do we interpret the diagnostic test results? Well, this is a complicated graph, but it's an important one for you to understand. Nasopharyngeal swab, PCR, bronchopharyngeal lavage or sputum with PCR, stool PCR, and isolation from the respiratory tract. We're going to look at those first before we look at IgM and IgG. So you can see with the nasopharyngeal swab, it rises, it gets to the zenith, and then you get to the inflection point, and it starts to come down fairly significantly around week 4. When we look at the bronchoalveolar sample, very similar curve. Symptom onset is here. So you contract the disease, you're asymptomatic for approximately a week, you're tested, and now we see this steady decline. Stool sample You get that later in onset, and it goes on for longer. But what is important is this. IgM, you get a fairly quick response and a fairly significant decline. And IgG are the antibodies that hang around for longer. And so we use the antibody testing. It's called an ELISA test, and it stands for the following. That's what I'm having done today. It's a blood test. And so IgM, you get a maximum response at around day 5, seroconversion in week 2, and then you get an increase in IgG. And here we can look at these antibodies that were detected, IgM and IgA and IgG. So IgM is a marker for acute infection, 1 day post-op, and IgG was day 14. The range was 1 to 39. So you can have antibodies, we call them neutralizing antibodies, that block the S protein. The monoclonal antibodies can be used for prevention and treatment of COVID-19. In other words, you can donate plasma to a sick patient. And so perhaps infusion of these antibodies as a pre-exposure or post-exposure prophylaxis may give you protection from infection if you're a healthcare worker. Convalescent plasma has been used successfully to treat critically ill patients. So if you've had the disease, you have the antibodies, donate plasma. And there are these point of care testing. And this is a little vague. Somebody tried to convince me to do this in our clinic, and I said it's not precise enough. So it's a little bit like taking a blood test for blood sugar. It's a pinprick. You then go ahead and add the reagent, and there are various interpretations. This tells you you're negative. This tells you that you're IgM positive. You have a good chance of being infected. This tells you that you have IgG. It means that you may have been infected a long time ago and is no longer infectious. I'm going to put a question mark there. And then IgM, IgG, both antibodies, you may still be infectious. It's too vague. So antibody testing is not the test of choice for diagnosing acute COVID, but it is useful as an epidemiological tool to understand the rates of community transmission. And so we know there's no neutralizing antibody level associated with immunity. With SARS-CoV-1, IgG titers peaked at 4 months, significant decline at 3 years, with no conclusive data on reinfection protection. There is no long-term data regarding immune response in humans for reinfection. They did do a study on monkeys where they infected the monkeys. They called it a challenge study. They waited a month later. They tested, the monkeys were negative. They reinfected the monkeys, and the monkeys were not acutely infected. They were able to mount a more robust response. So does a robust IgG response correlate with immunity? We don't know. And when we have a look at the rates of decline of antibodies, 50% of neutralizing antibodies are gone by 6 months. You get a 75% decline at 12 months. Here you are. If one is 100% at 12 months, you're roughly at almost 20%. So you've lost 80%. And you return to baseline approximately 3 or 4 years later. This is with coronaviruses, not COVID, by the way. Maybe you get around 45 weeks of protective immunity. And there is a seasonal aspect. So these are all strains of the flu, which are coronaviruses, and you can see throughout the year which months we are most likely to get infected with the flu. January, February, March, April, goes down in May, summer months, and then it comes back up. So the question is, will COVID follow the same? I believe it will. Okay. The interesting thing about COVID, what surprises you the most about coronavirus? It's done what no woman has been able to do. It's cancelled all sports, it's shut down all bars, and kept men at home. It's been interesting up to this point. Uvo, I want to break for a second and take any questions up to this point before we get into the dental portion.
All right. Thank you so much. Any questions right now? we have some questions here already. So is it true that patients that come down with coronavirus have a permanent lung damage?
That's a great question. They may have. I don't think there's been long enough data. I have a friend who got COVID. He lives in the Bronx. He's a pharmacist. He's Egyptian, and it takes a long time to recover. I got pneumonia last year, not COVID. I got pneumonia in January of 2019, and it took me a good 3 months to be able to breathe properly. So I do think there is potential for permanent damage, especially if the patient was intubated, was in the hospital, was critically ill. That they may have irreversible damage to their bronchi and their lung capacity may be impacted. I don't know, but I would suspect it's possible.
Okay. All right, there's another question here about CT scan finding for a patient with COVID-19 coronavirus. Yes. I guess it, yeah.
Go ahead, Uwe.
No, you said, what's the CT scan finding for a patient with coronavirus?
They have the ground glass opacity, and typically that resolves after a patient has resolution of the infection. And so, you know, they get a pneumonia, and it starts off as a viral pneumonia, and then sometimes they'll have a secondary bacterial or fungal infection on top of that. But there is resolution of that infection once the coronavirus or once the disease, whether it's just regular pneumonia or COVID-19.
Okay. Caller, are you there? Caller, you are able to speak. You have a question? Okay, while we're waiting for caller, you are able to speak. Okay, go ahead, caller.
Yes, thank you so much, the presenter, Dr. Ebrashi. I just want to make some comments. You said the discharge criteria require 2 negative tests.
Yes.
That are done within 24 hours. So I was wondering, because recently here in Nigeria, it's been reviewed to 1 negative test, and then the patient is discharged thereafter. And then I also want to comment on the statement on the fact that viruses doesn't survive in high temperature and high humidity. Yes, but there has been some studies that says even for this COVID-19 that this particular statement may not be true.
Correct, because it also depends on, you know, the virus isn't just sitting there naked; it's in a droplet. So it all depends on the viral exposure. There was a study, it was an in vitro study, where they looked at virus survival of SARS-CoV-1. And when you went from 33 degrees Celsius to 38 degrees Celsius, you had a 3-log reduction. So 5 degrees Celsius difference, granted it was an in vitro study, caused 1,000 X or a 3-log reduction in virus. So I think the temperature and humidity thing is vague. I agree with you. I don't think we should use that as any source of any type of data. And let's be honest, none of our clinics are 40 degrees Celsius, right? Typically, you're cooling down your clinic, your humidity is lower and your temperature is lower. But the virus does not survive very long on surfaces if you're able to disinfect and wipe. And we're going to talk about that. So I appreciate the comment.
All righty. Well, Jisha, are you there? Jisha Paniker.
Yes.
Go ahead.
Dr. Uwe. So I just want to say that this was a great presentation, and I just had a question. So, Doctor, have you seen any data regarding reinfectivity, like you know, a person getting the COVID-19 for the second time, and does the disease profile for such patients change in terms of, you know, the symptoms or the antibodies?
Great question. I have not been able to find data. The limited data I've found about immunity has been vague. I think people are really concerned because they were talking about immunity passports, where you've been exposed, you have the antibodies, and frankly, you don't care. So I haven't read anything about reinfection. I do believe there's reinfection potential because this disease is mutating. And if it's anything like influenza, if we develop a virus next year, is that virus going to be viable in the year 2022? And if it behaves like an influenza disease, which is changing rapidly, we will need to develop multiple viruses. So I don't know about reinfection. I haven't read anything about it. Have you?
No, but I've heard like a few cases where, as I said, I'm not sure about the authenticity of it, but where patients have been getting the disease for the second time. So that's why I wanted to ask you about what has research shown,
Yeah, there was one study that was from Japan, and what they found was the following. Patients went in and they tested negative. They then became sick and were admitted to the hospital. And what they said is, well, you were negative initially, but I think it was a false negative. The only research I've read about immunity per se has been with that monkey study, and it was a total of 9 rhesus monkeys. It wasn't a big study where they infected the monkeys. They waited, they did CT scan, RT-PCR, and they made sure the monkeys were negative. They then re-challenged or reinfected. They checked again, and the monkeys were able to mount a much, much faster response. So almost like having antibodies. So if you become sick with coronavirus, you then have IgG antibodies, or what we call anti-SARS coronavirus antibodies, right? If the disease challenges you again, those IgG levels are going to be high initially, meaning you're able to mount a more robust response. You may become sick, but your symptoms may be significantly less. I don't know. I do know that convalescent plasma has been used successfully. And so I think there's potential for a patient who's had the disease to donate plasma to other patients. And you can use plasma in 2 ways. Prophylactically, you can give a patient an infusion. You don't need much to have some IgG antibodies within your bloodstream. Or you can use it with critically ill patients, and you would need a much higher dose.
Okay. We're going to take 3 more questions here, and we're going to continue. I know I have a couple of people with their hands raised. I'll get to you. Anthony Umuna, are you able to speak? While we're waiting for Anthony, there's a question here from Chair. She says, what's the mode of transmission by asymptomatic patients?
Great question. I think that the mode of transmission by asymptomatic patients is going to be the same as symptomatic patients. They're talking, they're coughing, they're emitting droplets. Those droplets are falling on your keyboard. You're then touching the keyboard. I don't think the mode of transmission is different. The difference is we don't know that the patient is sick.
Yes.
Because they appeared normal.
Mm-hmm.
And so that's the problem with the disease. You have this silent transmission potential. Because think about it, if a patient is sick and they have a temperature and they're coughing and they have pneumonia, they're staying home. So the difference between SARS-CoV-1 and SARS-CoV-2, when patients got SARS-CoV-1, they felt really ill. They stayed home. They isolated and they quarantined because they didn't really have a whole lot of choice. They felt terrible. So they were out of the communities. The problem with COVID-2 is that they're able to circulate among us without knowing they're ever sick.
Okay. Mercy Oko, are you there? Mercy, Dr. Oko, can you hear me?
Yeah, I can hear you. Can you hear me?
Yeah, go ahead.
Yes.
You had a question?
Yeah, I have a question. Thank you, Dr. Sameh, for the presentation. It was quite interesting. Please, I want to paint a picture of what happens in my clinic. I'm a neuromedicine consultant, and I run clinic weekly, even in this era of COVID-19. I had an experience recently, an asymptomatic patient, because once they come in, you do this not contact forehead thermometer check. You say, okay, everything is fine and all that. What about the asymptomatic patient that come for treatment? And you have done this normal temperature check and it's normal, and it's sitting down in your chair, and you feel you are treating a patient that is not COVID-19 positive. And with that assurance, you go and order. I want to find, is there any other means we can, after doing the temperature check, that we can at least for this asymptomatic patient, because it's becoming a problem in my clinic, is there any other way we can actually say this patient is, we suspect the patient to be positive, apart from the the temperature checks
Great
that we
question.
normally do for all our patients. Yes.
Great question.
There are
Unfortunately,
so many asymptomatic patients right now coming to the clinic. Many of them no symptom, nothing. You do the patient,
Yeah.
fine, but only for you to come and the person is, if the person is close to you, say, "Oh, doctor, I just tested and positive," and the person was actually showing when you sell the patient. So I want to find out that we can do to protect ourselves as
the temperature testing is not very specific. So temperature testing is to be honest with you, you should be temperature testing your staff, because then you can monitor their temperature trends over time. That's more valuable. The patients, when they come in and they have a temperature, when you take their temperature, if they have a febrile illness, they may have, and it could be many, many different things. What is more sensitive is the change of sense of taste and smell. There's a study that came out from Europe. If your patient has a change of taste of smell, it doesn't even have to be no taste or no smell. Something like that is a highly predictive that they may have contracted the disease. Now, they may not be very aware of that, but really the only way for you to know whether your patient is negative or positive is to have point of care PCR testing, which is not going to be available across the world. We both know that. And even those Abbott ID machines, for example, that the White House is using, some people are saying those only have a 50% specificity. So there is no absolute way of knowing if your patient is positive or not. Even today, let's imagine today I go in and have my blood work, okay? And my blood work comes back positive to say that I've had antibodies. I could have had a test 3 days ago with the RT-PCR and tested negative, and that could have tested negative for two reasons. Number one, my viral load wasn't high enough to be detected.
Okay.
Number two, they didn't get an accurate sample. Number three, I had the disease. I'm now at day 12 or 13, and my viral load is so low it can't be detected.
All right.
So there's a window of time. So there is a study that shows if you can do RT-PCR testing and blood work, you have about a 91% accuracy.
All right. Thank you.
It all depends on the timing of the test.
Okay.
In other words, you could test today and you're negative. You test tomorrow, you're positive because your viral threshold got to that point.
Okay. Thank you so much.
Thank you.
All right.
Uvo, let's keep going, okay?
Yeah, go ahead with the stuff.
Great questions. I appreciate it. So let's talk about dentistry. Well, what are the implications of COVID-19 for you? Biologically, psychologically, socially? What are the implications for your staff? If your staff is anything like my staff, they're extremely nervous and jumpy. How do we minimize the risks to our patients, to our staff, and our families? How many of you are going home in the clothes that you wear in the clinic? If you are, you shouldn't be. I wouldn't. What changes do you need to do to practice safely? How practical are they? And are we ever going to get back to before Corona? Not anytime soon. So we need to understand the disease. And we can get a lot of information about SARS-CoV-2 from SARS-CoV-1. They're 80% similar. It is extremely sensitive to soap and heat and lipid solvents. And so we know that when we wash our hands with soap and water, if there is a viral particle on there, those molecules of the soap are able to break down the phospholipid membrane. The other thing that you should be asking your patients to do is not rinse with chlorhexidine. Chlorhexidine is not effective against the virus. You can use hydrogen peroxide, or you can use betadine, which is povidone iodide. And we're going to talk about that. That will kill the virus within 15 seconds. The problem is you have your patient rinse and then they cough. So the rinse perhaps is decreasing the bioburden, but I don't think it's if a patient coughs, then all bets are off. You got to pre-screen, like we were just talking. Ask your patients, have you had a temperature? Have you been exposed to anybody? Do you live with anybody with the disease? Make sure your patients are cleaning their hands. Clean all the surfaces in your clinic thoroughly. Wear a mask, wear a gown, wear goggles or a face shield, and try and minimize the amount of skin that is exposed to viral droplets. Viral droplets or respiratory droplets are a route of transmission. You will need some kind of respirator. Ask the patient, have you been anywhere that's high risk? Do you have any symptoms of a febrile or respiratory illness? Does your husband or wife? Patients shouldn't be in the waiting room. They should be in the car. You call them in when you're ready. Remove objects in the waiting room that can't be disinfected. We're not going to talk about patients with resolved COVID infection. Use a non-contact thermometer. That may make you feel better. It doesn't mean a whole lot for me. Have a patient rinse with hydrogen peroxide or povidone. You don't need to do it for 2 minutes. A minute will be adequate. Use disposable single-use items whenever possible, if you have them. Potentially use extra-oral radiographs versus intraoral because there's less gagging. This is kind of a joke. Avoid aerosol-generating procedures. Well, that's most of what dentistry is. This has been proved to be highly effective. Betadine, povidone iodide. And when we think about it, we use these in the ORs when we're cleaning patients' skin prior to surgery. And so this is their claim from the manufacturer. Kills 99.9% of bacteria and viruses. They use it in Asian countries for sore throat. Broad spectrum. Kills viruses, the leading cause of sore throat, in as early as 15 seconds. It decreases the bioburden. PVP iodide solution of 0.2% inactivated SARS-CoV-1 and MERS with 15 seconds in vitro contact time. So then there was a study that came out by BIDRA where they looked at coronavirus or COVID-19. And their hypothesis, their null hypothesis, was there would be no difference in the killing activity of the viruses of PVP at different concentrations and contact times, and there would be no difference between PVP versus a positive control, which is ethanol, and a negative control. It's always good to have controls when you're doing these studies. So they took SARS-CoV-2 stock and they tested it with 0.5%, 1%, and 1.5% povidone iodide, and they compared it to ethanol and water. PVP at all concentrations inactivated SARS-CoV-2 after 15 seconds. Ethanol was not effective after 15 seconds, but inactivated the virus after 30 seconds. Obviously, water did nothing. So this is something you can use with your patients. If you don't have it, you can use hydrogen peroxide. Again, everybody talks about this. My concern is what happens when a patient coughs or vomits. We had a patient the other day, we did an all-on-4 surgery, we didn't give him any anti-nausea medication, and he was vomiting. And one of my staff was in there without a face shield on. So we give people antiemetics if we're doing surgery. And this is really important, guys. So you need to focus on this. Think of this as a shield. This is your outer ring. This is the next ring. This is getting towards the middle. This is the second from most, and this is the bullseye. We're all talking about PPE. That's the least effective form of protection. The most effective form of protection is eliminate the disease, remove the disease. Test your patients if you can, if you're doing elective surgeries. Here in the US, if somebody's having a colonoscopy and so on, they're doing an RT-PCR test. Obviously, dentistry, if we're doing an occlusal amalgam, we're not going to do that. Engineering controls are very, very important. Administrative controls are very important. And PPE is the last piece. You need the systems, you need the staff, you need the stuff, and you need the space to be successful. Those are the 5 S's. The most effective is the outer ring. Eliminate, test. We still can't get our patients tested because all our procedures are elective. Eventually we'll be able to. And when you think of bioburden and activation, when we sterilize something, we need a 6 log reduction, right? When you're looking at spores for TB, you've got to go ahead and get those down by a factor of 10 to the power of 6. For virus, you've got to go 10 to the power of 3. So a log reduction value of 3, which is 1,000x reduction. And this is a complicated slide, so let's try and simplify it. We're not talking about bacteria or fungi, right? We're talking about viruses. And we're talking about envelope viruses. So as temperature increases, survival decreases. DNA viruses are more stable than RNA, so that helps us because it's an RNA virus. Relative humidity. Envelope viruses, which are respiratory viruses, survive longer at lower humidity. Non-envelope viruses, which are adenovirus and polio, they survive longer at higher humidity. Ozone inactivates airborne viruses, but that is problematic. And UV light harms them and can inactivate them. The problem is we're dealing with what? The oral cavity. And so there's saliva and mucus which can protect the virus from environmental changes. So that's a normal operating room. And then here is a negative pressure or an air room, airborne infection isolation room. In Singapore, they had these patients in these rooms and they tested the physicians as they were leaving. They had viral RNA on their shoes and they discovered viral RNA in the air vents. So don't think by putting yourself in an airborne isolation room that you're going to be able to eliminate it. You're not. And obviously that's unfeasible. What you can do is you can decontaminate your instruments well before you sterilize. Clean all surfaces with ammonium chloride wipes. If you have an OR, clean it with sodium hypochlorite 1,000 parts per million. You can vaporize hydrogen peroxide or hypochlorous acid. And you can use ultraviolet light. And we're going to talk about that towards the end. Again, another complicated slide where they're looking at different viral strains. So let's try and make this a little more readable. We're not looking at gastroenteritis virus. We're not looking at a mouse virus. We're looking at human coronavirus, the flu basically. Strain 229E. What they found was 70% alcohol for 1 minute, reduction of viral infectivity more than 3. So that's effective. Here, benzalkonium chloride and sodium hypochlorite, you need a 0.5% at 1 minute, that had a 3 log reduction. 0.1% again for more than for 1 minute, that was effective. And glutaraldehyde was not effective at a 0.01%, you need a 2% concentration. Now again, this is using a human coronavirus as a proxy for SARS-CoV-2. Okay? And if you log on to the EPA website in the US, Environmental Protection Agency, they have something called the List N, which products that have not been tested versus SARS-CoV-2, but they should be effective since they destroy harder to kill viruses and bacteria such as TB. And so you can use something called Cavicide. Look at the list and it'll tell you what you can use. So what does adequate PPP look like? PPP is a personal protective package. It's not just the equipment, it's the other things that you do. Hand hygiene at home, at work, wearing a mask outside of the office, being really careful how you put your PPE on and off, making sure you don't contaminate as you're doffing, taking it off, and don't use masks with a valve. Because if we're all wearing masks, my mask protects you from my droplets. Your mask protects me from your droplets. If you have a mask with a valve, guess what you're doing? You're saying, I'm protected, I don't care about you. So even just a regular level 1 surgical mask will help. And in the States now, they're starting to talk about using face shields in the community. I actually saw somebody in a supermarket wearing a face shield the other day. Healthcare workers rarely acquire infections during care with proper PPE. Infections may occur in the community when you don't wear your PPE or your face mask. Could a face shield, if universally adopted, bring R0 down to below 1? Firstly, we don't have enough face shields. We obviously don't have enough N95s. But we can make homemade masks. Homemade masks are better than no mask. So let's look at this study, which was a lab study where there was a patient cough aerosol simulator and a worker breathing with a mask on simulator with a face shield. Okay, 24 degrees Celsius, relative humidity 23%. What they found was with the large particle cough, there was a bimodal distribution in diameter. It went all the way from below a micron to over 100 microns with the large particles. And with the small droplets, here, you can see it's a regular bell-shaped curve. That's about 1.5 seconds after the cough. Now look at the nose shield compared to a face shield. What's happening at the volume of aerosol particles inhaled. When you're roughly 46 centimeters away, it made a difference. 183 centimeters, there was a difference with a large aerosol. And with the small aerosol, there was a fairly significant difference when you're 6 feet away. Now have a look at the number of influenza virus copies without a face shield, with a face shield, and on the mask. Clearly, with the face shield, there's a huge difference. Middle column. At 183 centimeters, there really wasn't. And that makes sense, because most of the droplets aren't traveling 183 centimeters. So when we see aerosol, smaller particles that are airborne for longer, they flow around the face shield at 183 centimeters, but the big droplets are protected or prevented from hitting you in the face or to being deposited on the mask. And that's coming up. Inner layers of the respirator. No shield, shield. Inhaled without a face shield, plaque forming units. Inhaled with a face shield, big difference. So face shields, if you can get them, use them. And the goal is to bring the R0 below 1. That's what I look like on a surgery day. Pretty uncomfortable, pretty hot. I'm covering my hair. I've got a disposable gown that's being tossed away after surgery. And so let's talk about masks. Level 3, level 2, level 1. The 5 F's. Filtration, fluid resistance, features, fit, and how it feels. The higher the filtration, the more difficult it is to breathe. The better the fit, the more protection you have. So if we go back, a level 3 mask has a filtration efficiency better than a level 2, which is better than a level 1. Submicron particulate filtration is more than 98% at a 0.1 micron. What size is this virus? It's 0.12. But the virus doesn't just hang around by itself. It needs a drop to attach to. So if our droplet is 1 micron, and an N95 is effective against 0.3 microns, that should do it if you have it. If you don't have an N95, it's not the end of the world. Try and get hold of a level 3 mask. Right? So an N95 filters 95% of the airborne particles, an N99 is 99%, and an N100 is 99.97, not resistant to oil. There's something called an R95 and a P95, and those are different types of masks. And the way it works is there are several layers, but really it's relying on an electrostatic charge. So an N95 filtering facepiece respirator seals to the face, filters out 95% of non-oil-borne airborne particles. It's preventing the particles getting to your nose or your mouth. And the way it works is it has this interlaced fibers, that are polypropylene, that are electrostatically charged. And what they do is they trap the fibers. It basically acts like a blanket in a dryer because of the electrostatic charge. So if these become degraded, then it doesn't work as well. And there's a paper that came out, because obviously there aren't enough to go around. What about use and reuse? If you think your patient has COVID, you can only use that mask one time. Now, one of you who's smart is going to say to me, well, how do I know if my patient has COVID? You don't. But if you know if your patient has COVID, everything that you've worn gets thrown away. In a patient with low suspicion of infection, reuse of N95s is okay with the following caveat. Hand hygiene. Do not touch the outside or the inside of the respirator. Inspect and perform a seal check. Make sure you're not leaking. Avoid removing or adjustment with the inner and outer surfaces. Store in a clean, dry location if you can. And discard if it's contaminated, damaged, or leaking. And 3M has a lot of literature on its website. And what they're saying is, healthcare workers should treat the filtering facepiece respirator as though they are still contaminated and follow precautions outlined. If supplies are more constrained and 5 respirators are not available for each worker who needs them, FFR decontamination may be necessary. And so to decontaminate, there are various things that you can do. And they think that vaporized hydrogen peroxide works. You send them somewhere, they put them in a room, they use, I don't know how many parts per million hydrogen peroxide. You write your name on your mask, you get it back, but it is not sterile. These are the things that damage the filtration: soap, alcohol, bleach, and gamma radiation. Overnight storage does not inactivate a virus. UV A or B light from a nail salon doesn't. Sunlight doesn't. Inadequate time, inadequate UVC, or insufficient UVC. The other thing about radiation is it can affect the electrostatic charge on your polypropylene fibers. What did we learn from history? This slide is from 1919 in San Francisco. Keep your drops to yourself. Use a mask all the time. None of my staff is allowed to walk around the clinic without a mask on, at all, unless they're in the break room eating or going to the bathroom. So what does the evidence from Oxford say about masks? Standard face masks compared to respirators in preventing COVID-type illnesses. Standard surgical masks are as effective as respirators for preventing infection of healthcare workers in outbreaks of viral respiratory illnesses such as influenza. There are no head-to-head trials of these masks on COVID-19. And neither type of masks prevent all infection. Both types of masks need to be used in combination with other PPE. Here are the studies that they had with influenza. Pretty significant number of people wearing masks. Difficult to do a study with no mask as a control, because if the healthcare workers are wearing masks and the patients have influenza, tough to say don't wear a mask. So they compared a standard mask compared to a respirator mask, and this is the percentage of folks who got influenza in this study. Radonovich, this is a good study. They followed people for 4 years, every year giving them, randomizing and giving masks versus respirators. There's no difference, 7.2 to 8.2%. And N95 is not going to give you absolute protection. Please don't believe that, it won't. A significant percentage of healthcare workers were infected despite masks. The absolute numbers vary. Nothing can be concluded from these studies, most of which are to do with influenza, regarding incidence of COVID-19, because we haven't done any studies to compare a mask versus a respirator with COVID patients. If in doubt, act. As with parachutes for jumping out of a plane, you got to act without waiting for a randomized clinical control trial. Masks are simple, cheap, and effective. They significantly decrease community transmission if universally adopted. Sadly, in this country, masks are now being portrayed in a political light. Republican states, people look at you as if you're strange if you are wearing a mask. Democratic states such as Oregon, people look at you as if you're a weirdo if you're not wearing a mask. You need to wear a mask. I absolutely believe it. My kids, when they go back to school in September, will be wearing masks, for sure. And look at this still photograph of a patient coughing. This is from Japan, sneezing. Look at the droplets. And then look from behind the patient at the cloud that's emerging. So airborne spread is a thing. When you breathe, you produce droplets. When you talk, you make droplets. If you need to understand what louder speech and droplets look like, view a video of Adolf Hitler speaking and see the amount of spit coming out of his mouth. When you sneeze and you cough or you vomit, you produce droplets. When you sneeze, you produce 40,000 droplets roughly at 100 meters per second. When you cough, it's 3,000 droplet nuclei or aerosols. Super spreaders, 20% of patients equal 80% of the infective viral particles. There are certain patients who can produce 500,000 droplets. And what they found with the influenza is when you're sick, not only do you produce more droplets, they actually travel further. The question is that the same with COVID? In the outbreak of SARS in Hong Kong in 2003, patients who wore face masks, the rate of SARS was 28%. The patients who did not wear face masks, in their communities, infection rate was 59%. The droplets that are produced depends on which part of the laryngeal tree or the respiratory tree. So you've got bronchial drops that are roughly produced during breathing that are about a micron. Then you've got laryngeal mode from breathing or talking, more than a micron. And then you've got the oral cavity, speech and coughing that are more than 100. But we've got to look at this as more complicated versus big drops and small drops, what I call a dichotomous model. How do large and small drops behave in a gas cloud? And how does temperature and humidity affect them? Look at this. When you sneeze, that's 8 meters. So there's a locally moist and warm atmosphere and a turbulent cloud, and the droplet lifetime is extended by a factor of 1000x plus. These can be in the air for minutes, because this is a very complex system. So somebody can sneeze in the bathroom, you go in there, and those droplets are lingering. And look at the difference when you wear a mask. So this is a study. Actually, if you log on to the New England Journal of Medicine, they have a video that you can watch. With a patient not wearing a mask saying, "Stay healthy," with laser light scattering, look at the droplets that are being emitted. Same patient, same volume, with a mask saying, "Stay healthy." This is huge. So simple. So when we look at this study, which is a preprint, has not been peer reviewed, looks at no mask, homemade mask, surgical mask. Look at the reduction in the droplets with different sizes. 0.65 to 1 micron goes down by 71% with a homemade mask. 1 micron to 2.1 micron goes down by 84%, 85%, and with the larger drops, not a significant difference. 20%, 60%, 67%. Homemade masks work. They're not as good as a surgical mask, but it's better than nothing. And a patient who flew from China to Toronto with a mask, who subsequently tested positive for COVID-19, the 25 people closest to him all tested negative. All of them. Nobody got sick on that plane. Conversely, in that choir in Seattle, 60 people singing for 2.5 hours, one patient got sick, one patient was sick, passed it to 45 people, and 3 died. No masks. So let's talk about aerosol, which is what we're all worried about, and this paper in the New England Journal of Medicine. And they looked at aerosolization of SARS-CoV-1 and SARS-CoV-2 with different materials: copper, cardboard, stainless steel, plastic, and so on. And This experiment was limited to small particles only. It wasn't just like a cough or a sneeze. And SARS-CoV-2 was viable in an aerosol throughout the duration of the experiment, about 3 hours. Stuck around on copper for a long time. Went down from a 10 to the power of 3 to 10 to the power of 1 within about 24 hours. Stainless steel a long time, and plastic for a significant amount of time. The half-life, it behaved similar to SARS-CoV-1, no surprise. So when you look at the half-life of the viral titer in an aerosol, copper, cardboard, steel, and plastic, very similar graphs to SARS-CoV-1. And there was a paper written, or a rebuttal from the WHO. A recent publication, the New England Journal of Medicine, has evaluated virus persistence. In this experimental study, aerosols were generated using something called a 3-jet collision nebulizer fed into a Goldberg drum under controlled conditions. This is a high-powered machine that does not reflect a normal human cough. Further, the findings of COVID-19 and aerosol particles up to 3 hours does not reflect a clinical setting in which aerosol generating procedures are performed. That is, this was an experimentally induced aerosol generating procedure. So what are the unanswered questions that I have, or you may have? To answer these questions, we need to combine virology and aerosol science. Do infected but asymptomatic patients emit more aerosol versus a healthy patient? Do these aerosol particles change with time? What's the best animal model for simulating airborne transmission of COVID? What is the effect of the ambient environmental condition, temperature, and humidity on viral viability? That speaks to the comment from the gentleman from Nigeria. What is the optimal protocol for sampling by aerosol? What is the average viral titer in respiratory fluid? What's the minimum infectious dose of COVID? And if Uvo and I both walk in the same room, will we both get it? No, because we're different patients. How do we assess the virulence of aerosolized viral particles? And what is host immunity impact? How does it impact disease progress? A lot of unanswered questions. And so, what should I do? Well, you do the best that you can until you know better. When you know better, you do better. Let's talk about the built environment, where we live and work. Potential vectors are human interactions, contaminated objects or fomites, and airborne transmission. If you can effectively disinfect the air with 6 to 12 room air changes per hour, you may have a better chance. If you can use an upper room germicidal UV fixture, that can kill viral particles. And here is an illustration of viral infection. So the viral particles are expelled as droplets, either through talking or coughing. They then can cross-contaminate our hands. We can put them on a keyboard. We can put them on the handle. Somebody else comes along. They touch this abiotic surface, then they touch their own eye. So there is potential for contamination from dirty surfaces. Open clinics are a problem. You're going to have to go to something more like this if you can. So we need to look at air changes, filtration, distribution, and room pressure. There's typically supply air and return air, right? And so there's not a lot of data regarding dental offices, but for medical facilities, a patient room is 4 to 6 air changes per hour. Airborne infection room, which is a negative pressure room, is 12 air changes, and an OR is 15 to 20. Chances are our dental clinics are something like this. There's something called a MERV rating, the minimum efficiency reporting value. What we need to have is a MERV filter of roughly 13 and above, or a HEPA filter in our clinics, if you can get those. And so a patient room has a MERV rating of 14. An airborne isolation room has a HEPA filter, which is 99.97% effective against 0.3 microns. And an OR is MERV or HEPA. And so you want to avoid stagnant zones. So your air distribution is important. If your inlet is like this and your outlet is like that, and this is where you sit, that's okay. But if your inlet is here and your outlet is there, look at all this stagnation you have. You want to have overhead inlet and exhaust. Actually, you want to have overhead inlet and you want exhaust down here, and I'll show you why. If you do this, you have a stagnant zone. Important that you understand where the patient is sitting relative to the exhaust and where the assistant sits. What happens if you have two inlet valves and an outlet valve directly over the patient? That may help. This is the ideal situation. Multiple inlet valves and outlet valves low, and that's how an OR looks like, an operating room. Overhead air supply, the return air inlet valves near the floor. Aerosols from the patient are being pulled down to the floor and being expelled. What about room pressure? What are the consequences of a positive versus negative pressure? Positive pressure means you're getting more air supply than return. So air is being forced out of your operatory into the corridor. We don't want that. What we actually prefer is a negative pressure room, where you have more exhaust than inlet. So there's more exhaust from the HVAC versus supply. So air is being forced to leak in, presuming your corridor is clean and you don't have contamination. You definitely don't want to have aerosol coming out of this room into the hallway or recirculated air for sure. So a negative pressure room was obviously kept negative because of the airborne illness. You're not going to be able to do that, but if you can have a higher exhaust, that would be preferable. So dental operatories should be negative, prevent aerosol from leaking out. I hope that makes sense. And you can use a HEPA filter. And the HEPA filter stands for a high efficiency particulate air filter. You can combine it with germicidal UV radiation, and it's filtering out particles via sort of a web of interlaced fibers. You can also use this UVGI. And what we're typically looking for is not UVA, not UVB. We want UVC, which is around 250 nanoparticle, and they're using that in some of the ORs. So 10 minutes of UVC light inactivates 99.9% of coronaviruses tested, including SARS and MERS. I would suspect that SARS-CoV-2 is going to behave like these. The problem is shadowing. So you can get around it by the following: by putting upper room UV radiation. You irradiate the air high up in the room, you then recirculate the air. You're getting a high number of air changes per hour and a significant germicidal effect from here. Now we're starting to come up with the concept of far UV light. The problem with UVC is that it can cause cancer and corneal damage. So your staff cannot be in the room. But UVC, which is 220 nanometers, has limited penetration of biological material. It's still germicidal. It does not penetrate the epidermis or the cornea, so it will kill viral cells, but it won't damage the melanocytes and have a carcinogenic effect on human skin or the cornea. What about population density? This is New York City, Central Park and the Bronx. They did a study recently where they looked at patients seen at hospitals that were coming to have children again, to have babies. They tested them for PCR. They looked at mortality and hospitalization rates, and they looked at the demographic data, housing, and tax data. And they looked at the following things: number of residents per building, residential units, the value per square foot, the median household income, unemployment rate, population density, number of residents per house, and household crowding. Percentage of households with more than one person per room. So in a city like Lagos or Cairo, obviously you've got very high density with significant number of folks sharing a room. And what they found was the following. When you look at the vertical axis, the probability of SARS-CoV-2 went down as the income went up. It also went down as the price per square foot went up. Not surprising. Lowest probability for patients living in areas with high assessed values. When you look at household membership, it went up as you had more people cohabitating, and unemployment rate too. And then when you have a look at household crowding rate, it also went up with more than one person per room. Highest probability of infection for people living in neighborhoods with high household membership, maybe up to 24% with a range of 18 to 30. No statistically significant association between SARS-CoV-2 and population density and poverty. So to wrap up, what are the things that we can do? Barrier measures, PPE, masks, isolate sick patients. You wash your hands as many times as you can per day. Suspicion, diagnosis, and quarantine of infected patients. Efforts to reduce transmission from kids. These are my two. This is Zain and Sophia. I'm concerned about when they go back to school because they may be exposed and bring it home. Chances are I would have probably done it already. Our responsibility is the following. You got to protect the public. Can't treat patients like they have leprosy. This is an Egyptian actor. You can't treat patients as if they're radioactive either. Make well-informed decisions. Educate yourself. Educate your staff. Educate the public. Try and minimize the sense of panic. COVID-19 may become less virulent. It may follow a similar path to SARS-CoV-1 and MERS. We've been down this road before with HIV. I know HIV is not an airborne transmitted disease, but we've panicked in the past. And so to wrap up, the 7 C's, be calm. Try and maintain a sense of calm. Your staff is looking to you for guidance and leadership, as is your family. Be confident. Have a plan. Today's plan may not work tomorrow. That's okay. Adapt if needed, or when needed in this instance. Communicate. There's no such thing as too much communication. Collaborate. Talk to your staff. Get feedback. Talk to your patients. Talk to your friends. Have a sense of community. Try and support your friends. The guy that bought my old practice didn't have enough PPE when March came around, or when May came around. I had plenty because I worked for a corporation. I may or may not have lent him some stuff or given him some stuff. Have some compassion for people. People are nervous. People are anxious. That's a very important thing. Last of all, cash is king. I don't really give that too much credence because that may not be in your control, but all these 6 are. Thank you so much for your time. I'm honored and privileged to be able to speak to you. I am from Africa. I'm proud of my heritage, and I really appreciate the chance to talk to you.
Thank you. Thank you so much, Dr. El-Ebrashi, for this very late, it was worth every second of it. I mean, you can attest to it. Everyone out there, I've just been thinking, if we can get 2C credits for this course available to folks, especially those in Nigeria. I know we have a lot more high percentage of Nigerian dentists on this webinar today. And also, I'm thinking, Dr. El-Ebrashi, what do you think?
What? Think about what?
We could make the video available, and but I'll need for you to give me a couple questions.
Sure, I've got lots of questions, Ugo.
Okay. Yes, I'll get the questions and the answer options and put it in a survey so that we could put it recorded for those who were not here today, so they can have access to it. And if you answer the questions correctly, 70%, you get 2C credits.
Just FYI, Ugo.
Yes.
They're not easy questions. But the answers are all in the presentation.
Yes, I mean that's the essence of it. We want people to be able to go through this is a lifesaver as far as I'm concerned. Just doffing, just the protocol for doffing your PPE. You just need to follow it to the letter if you're to be safe during this period. Thank you so much. I really appreciate it. Any questions out there? If you have any questions, Akideno, your hands are up. You have a question? You can talk, Akideno. Albert? Albert, you're able to speak if you want to. Go ahead, Albert. Albert, I can't hear you. Are you saying something? I think you should type it in. Your network is dragging a little bit. I can type in your question, Akideno. Type in your questions. Your network is dragging a little bit. Any other questions out there? All right, Dr. Ebrashi, I don't think we have any more questions. Or let me see. I see something in the chat. Let me check and see. Many thanks. Okay. No questions for right now, but we'll have an opportunity to go through those. Thank you so much. You guys take care. We'll talk tomorrow. We're going to have another session tomorrow on Sunday. So please share the word and let others get involved.
Thank you. Thank you. Talk to you later.
All right.
Bye-bye.
Thanks.
Bye-bye.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator